Thank you. Hello. Hi, Lars. Hi, Tony, Elizabeth, Hilda. Thank you very much. So now we've got the technology going so far, fingers crossed. As I said, I'm going to talk to you about my research interests and my personal research interests, but also the work of the Interdisciplinary Research in Health Sciences group that I'm based in at Oxford. So my research interests are really, I'm interested in a critical analysis of the relationships between health and social care policy, practice and lived experience. And I'll say a bit more later about why I've become so interested in those relationships between policy and practice. I've got a broad interest in how patients and the public interact with health and social care services. And I've developed over the last couple of years specific interests in how these interactions are shaped by the complexity of health and social care systems and technology. So the structure of my talk today, I'm losing my ability to move my slides, which is annoying. There we go. I thought I'd start down at the bottom with a short description of the SHEtalks project, which I've been working on over the last couple of years, and then build up and talk a bit about two of the case studies I've developed and some of the public engagement we've done for the study. From that, we've developed a framework to think about complexity in health and care and technology. And I'm going to introduce you to that. If we have time, we'll see how we go. I'd like to share how I've brought that approach to my current projects, which are around shared decision-making and video consultation. And then to finish by talking about how these perspectives may contribute to virtual presence. And it'd be nice to get some feedback from you about that. So I'm going to start, I was going to mention virtual presence, but Ivan has already done that. So, and there's many people on the call much more familiar with the project than me. I'll start by talking about SHEtalks. SHEtalks stands for Studies in Co-Creating Assisted Living Solutions. And this was a major program of research headed up by Professor Tricia Greenhalgh. There's a little picture of her there. And it was funded by the Wellcome Trust. And this was the first research program that I've worked on. We started back in 2015. It was due to end this year, but we've actually had a short extension because of the pandemic. We've pretty much finished all of our empirical work, and we're just finalizing some of our written outputs and our publications. SHEtalks set out to be a fourth generation study of assisted living technologies in their organizational, social, political and policy context. And we developed a series of organizational case studies, considering those cases as part of complex systems. Our approach was to decenter the technology. Rather than studying the technology itself, we aimed to understand the effects of the technology in the course of people's everyday lives and their care. Now, when we talk about fourth generation studies, we categorized in our protocol paper, previous studies of assisted living technologies into first generation studies, which were to develop technologies and demonstrate proof of concept, i.e. to see that the technologies worked in particular conditions. Second generation studies we categorized as experiments or randomized control trials, which tested if the technologies achieved specific outcomes, usually in comparison with a control arm or with usual care. Third generation studies we categorized as those qualitative studies, particularly led by social scientists, many of which you'll be very familiar with, that looked at the experiences of technologies and the awareness and took an awareness of the social and material context into which those technologies were being introduced. Now, the idea of a fourth generation of studies is to say that neither the technologies nor the people who use them can be studied in isolation from the complex systems in which they are embedded. So we proposed that there was time for a paradigm shift and to take fourth generation of research, which is interdisciplinary, embraced complexity. It was recursive, so it looked at the links between the micro, meso and macro structures of society, is ecological, so looked at technologies in context, and was critical. So we looked at the interests that technologies might serve. So the kinds of questions we asked and that we might ask from a fourth generation study of technology might include, what does the device mean to you or to the person who uses it? How has it come into your life? Who pays for it? What's it worth? Who regulates it? Who benefits from it being used? What happens when it goes wrong? I wondered if you might want to engage with these questions directly right now. So perhaps you could think about a device or a technology that you know. It may be something you've studied, or it could perhaps be something as simple as the device you're using to connect to this call. Have a think about that technology. Perhaps post some thoughts in response to these questions. I'll keep going with my talk, but perhaps you could multitask and post some comments whilst you're listening. Now, these questions, for those of you who are social scientists and STS scholars, they may not be questions that are particularly novel or new for you, but please bear in mind the situation within which our research takes place. I'm based in a group of social scientists and interdisciplinary scholars, but I'm based in a department of primary care health sciences. We sit within the medical sciences division at the university. So we work alongside epidemiologists, we work alongside clinicians, and we work alongside people with who work within very different paradigms to the kinds of questions that we're asking. But I think what's important is to bring together those different approaches. And our research aims not just to study technology, but to try and help people use technology and implement technologies in important projects. So I can't see anything in the chat yet, but I'm hoping you're all thinking about your technology and thinking about some of these questions in relation to it. We're going to return to some of these questions when I look at the framework we've developed from the SHEtalks research. What I want to do next is to move on and talk about two of the case studies I've been directly involved with SHEtalks, and also some of the more general work we've done across the programme. So the case study that I worked on first in SHEtalks was around integrated care. And this is actually the time I'm going to take a short digression and explain a little bit about my slightly unconventional route into research. I only started working on the SHEtalks programme back in 2015, and I started doing my doctoral research as part of the programme. But prior to that, I'd already worked for almost 20 years in the public sector in the UK. So I had a previous career before coming into academia. When I graduated, quite a long time ago now, with a degree in philosophy and literature, I went to work for a charity for homeless people in London. I grew up in a very rural part of England. I grew up in Cornwall, a very beautiful place, very coastal, full of beaches. And I was desperate to get to the bright lights and big city of London. And I went to work for a charity with homeless people, and I spent a lot of time working directly with homeless people who were living on the streets, who were living in hostels. And I got very interested in the structural conditions that led to those people living in those circumstances. I got particularly interested in social policy and how policies had led to the problems of homelessness, and in how effective or not those policies were for the people that I was working with. This interest led to me pursuing a master's degree in social policy and planning, and that in turn sparked my interest in health policy and a career in the NHS. Cutting a long story short, I ended up working in commissioning in the NHS. That's a role that involves the strategic planning and purchasing of health services. By 2010, I was asked to lead on a programme of integrated care across one area of London, and that was concerned with integrating health services with social care services. The overall aim was to provide better coordinated care in the community with a focus on people with multiple long-term conditions, mainly but not exclusively older people. The idea being that that would reduce hospital admissions and save money. But when I looked at the evidence on integrated care, there was little to support these policies that I was being asked to work on. And that really triggered my doctoral research questions. I ended up creating an in-depth case study. I ended up learning quite a lot about social theory and produced multiple accounts of integrated care. I did a policy discourse and narrative. I looked at different sites of integrated care. I looked at how integrated care is experienced by individual people and their families and people around them to manage complex conditions. And I developed multiple perspectives on this problem, this phenomena of integrated care. Now, I'm not going to say much more about integrated care. I've written quite a lot about it, and I'm always very happy to share those publications and talk to people about integrated care. But what I wanted to do is to bring us back to the SCALS study. My case study of integrated care was a good example where we decentered that technology. I didn't pursue a particular technology in my study, but I found technologies in use. So, linking back to some of the other case studies across SCALS, one of the ways in which I got involved in those other cases was through a public engagement programme. As I said earlier, SCALS was funded by the Wellcome Trust. Wellcome really promote public and citizen engagement in science and research. And whilst in SCALS we had done lots of engagement with patients, we'd done much less with the public as citizens. One of the findings across our case studies was that hopes were often very high that the technologies we were studying would be able to improve health. And indeed, hopes were very high that we would easily be able to implement those technologies. But for some of our case studies, we were finding it hard to find empirical data because the technologies, although they were supposed to be in use, when we investigated, actually some of them weren't being used at all. The reality of implementation was often disappointing. And when technology was used, it wasn't always used as it perhaps was intended. When it came to individual people using technologies in their homes, we found that people often had to adapt or modify the technology, particularly thinking about the lives of older people who had several medical conditions and social needs. That's the cohort of people I've been looking at. Actually, in practice, people had to do a lot of work to adapt and modify their technologies. A lot of tinkering and bricolage. Again, these concepts will be familiar, I'm sure, to many of you, and have been written about previously by colleagues on my group and also by other scholars. So we thought this was a really interesting avenue to explore. And we did this in a public engagement project, which we called Messy Realities, to reflect the messiness of the reality of using technologies. And this was a project we ran in partnership with the Pitt Rivers Museum in Oxford. Now, the Pitt Rivers Museum, you have to bear with me, this might feel like I'm going off on a bit of a tangent, but it is relevant. The Pitt Rivers Museum is a museum of anthropology and ethnography. It's a wonderful place. If you ever get the chance to visit Oxford, I recommend you go there. But the great thing is, at the moment, you can actually do a virtual tour, and this is their website and the web address is there. They've recorded a video of touring around the museum. Now, the museum takes, and this is the link back to our study, the museum takes an unusual approach to its displays. The artifacts in the museum are arranged by type into what they call a democracy of things. So you might, for example, have a case in the museum which contains lots of different solutions to create light, lamps, light sources from around the world. There's another case that has writing implements. So instead of artifacts being grouped by a time period or by region of the world, they're grouped in the ways in which people have found solutions to common problems of humanity in different environments and different cultures. So what we did, we took our technologies that we had found in our studies, or that we had been specifically studying in our SCALS project. We took them into the museum and we put them in conversation with the museum artifacts. And we discussed those with some visitors to the museum, with a community group of older people living with various life-limiting conditions and using different assisted living technologies. So here we have a pendant alarm on the right. This was a very common, a very everyday, mundane piece of technology which many older people were using in my study site. Used to call, there's a button in the middle. I'm sure people will have seen these things before. You press that if you were to fall or need help in your home, and it would connect you to a call centre who would send someone to help you or phone you or talk to you through a radio receiver. We put that in conversation with, on the left, we have an amulet. So something you might wear around your neck to help you feel safe and connected to perhaps your spiritual advisors, or to bring you good luck. Bringing these objects together made us think very differently about the symbolic meanings of technology, about how technologies worked and how they were understood to work. Now, again, one of my colleagues is an anthropologist, and for her, this wasn't particularly novel or exciting. But for those of us that have been working perhaps within a more biomedical framing, this was quite interesting and new for us. And what was really nice was that our community members completely understood and appreciated this. I've got a few more pictures to show you from that project. We took Paro, the robotic seal. Paro there is on the left, with Jean, one of our community members. We weren't researching Paro, but people had heard about Paro and wanted to meet him. So we found somebody who was researching Paro and brought him into the museum. I don't know, has anyone here on the call met or know about Paro? Paro is was developed in Japan and is a robot. It's a cuddly creature, as you can see, but it's full of complicated artificial intelligence. It's commonly used to help people with dementia, to provide them with stimulation and prompt social interaction. Paro is used apparently quite widely in Japan. Paro is used a little bit in the UK, but maybe not so much. But it was very interesting to bring this robot into this museum situation. We also had some interesting discussions about conservation and made some parallels between issues of conserving, preserving life and the life of objects and the life of people. I'll just show you one more picture where we brought some mundane, everyday technologies. Here we have walking devices, a walking frame, which is often called a Zimmer frame, and some very mundane walking sticks, compared with some of the artifacts in the museum. And this juxtaposition, this bringing together of very different items, really made us think about issues of status and stigma around health and illness and disability and aging, and different approaches to that around the world. If you're interested in this work, we did create a series of podcasts. So, and those podcasts include members of the community talking about their experiences of using different technologies. I think I put the link up in the previous slide, but I can share that again. So what's the relevance again to our work? What we found was that the different layers of meaning that these technologies had inspired made us think differently about some theoretical work we might use in thinking about our technologies. And in particular, a paper that I worked on with Sarah Shaw's, picture of Sarah there, where we took a post-phenomenological approach to analysing care organising technologies. We took this concept of multi-stability from post-phenomenology. Multi-stability refers to how technologies have different meanings, how they become different things and perform differently in different situations, in different contexts. And we thought about how those technologies affected people that use them. So I had not encountered post-phenomenology prior to this, writing this paper with Sarah. I don't know, does anyone else here know anything about post-phenomenology? Is anyone here an expert scholar in the area? If you are, put your hand up or put something in the chat. No one's going to acknowledge that. I will keep it brief. There are some references to this talk as well, so at the end. So if you do want to follow any of these up, please feel free to do so. So post-phenomenology is a term that reflects the strong influence of phenomenology and a focus on subjective experiences of the world, but uses the word post to indicate a concern with empirical investigations of technology, to indicate a break with previous studies of phenomenology, which are perhaps a little abstract about how technologies are experienced. Post-phenomenology focuses on the relationships between users and technologies and asks how technologies shape our choices, actions, and experiences of the world. And post-phenomenologists talk about different kinds of human-technology relations. Embodiment relations are the kinds of relations you would have with a piece of technology that transforms how you engage with the world, that you become almost unaware of. A typical example is the use of glasses, spectacles, or even contact lenses. You wear them, you don't know you've got them on, but without them, your experience of the world is very different. Hermeneutic relations are the relations we have with technologies when we read an output. So that might be something like an MRI machine that scans your body in a hospital, or it might be something as simple as your watch telling you the time. You're reading the output from the technology. Alterity relations are when you engage with the device, where it becomes a quasi-other. So where your device or your technology is talking to you. This might be a prompt box on your computer. If your laptop screen comes up, and if a box comes up on your laptop and says, do you really want to delete this document? It's that kind of relationship. Or it could be something more complex, like engaging with a chatbot. Background relations are when we've got technology going on which really shape our experiences, but we're not engaging directly with the technology. The example that's used here might be an air conditioning unit. It's changing the temperature of the room that you're in, but you're not necessarily aware of it. We extended and added in this paper a new category of technology-mediated relations, and we added the category of dissonant relations. Now, this came from work we've done where we looked at how carers, informal carers, usually people in their 50s, 60s who were caring for very elderly parents, we looked at how they were using technologies that had been designed to help them do those caring jobs. The technologies were apps, two applications that were generally used on smartphones, two were designed specifically for carers, and one was a more general messaging service which people used to organise care. Typically, they were designed to help organise care, and we looked at the idea of scripts embedded in those technologies. So one way of thinking about providing care for an older person was to think of all the jobs that they needed doing. They might need help picking up their medicines. They might need some shopping done for them. They might need a leaky roof in their house fixed. They might need someone to take them to hospital. The thinking was that there would be lots of people available to help them with these jobs. There might be adult children or even adult grandchildren. There might be neighbours, friends. What we need to do is to organise those people and organise those jobs, and your app could help you do that, which is great if you've got that nice extended network of support. But we found at least one case where a family member found the idea of using that technology really quite upsetting and distressing. This was because her situation was in a family dynamic that was very difficult, very complex and fraught. There wasn't a helpful set of relationships. In fact, there was a very difficult set of relationships. There was a lack of care being provided. Introducing a technology designed to organise the tasks of care into that situation was potentially really explosive. It magnified the emotional aspects of care, and it led to this outright rejection of the technology, which we termed a dissonant relation. So, to move on, one of the themes I think I could probably talk about actually is when things don't work, when things aren't adopted, when integrated care doesn't work, when care organising apps aren't popular with carers. And we learned an awful lot for when things were not adopted or taken up. But what we needed to do with the SHEtalks case study was to think about the connections between those different cases. And we sought to produce a framework which provided a way of bringing together all of the learning from across those different cases. And the result was the Nas Framework. Now, what I thought I would do is actually show you, we've got a little video that introduces Nas, and it will give you a break from me talking. It's 1 minute long. I'm going to try and play it. Very simple. It was designed to introduce the idea to people perhaps working in health and social care who might need to think differently about their technology projects. So let's see if I can play it. It's on YouTube. If it doesn't play, not the end of the world. Can you hear that? No, I think I need to change mine.
Badly.
Let me see.
We can see it, but we can't hear it actually.
Okay, what I need to do is to share my computer sound. Let's try now.
Complicated problems needing lots of rules and processes, and complex problems like these.
Right. Let's see if I can take it back to the beginning.
As health technology moves from early tests to the real world, actual usage drops off fast. Tools that seem to deliver at first struggle to integrate into complex health systems and patients' lives. The problem is complexity. There's a difference between complicated problems, needing lots of rules and processes, and complex problems like these, where there are too many interacting factors, too many unknowns even to write a rulebook. This isn't rocket science. It's more like seeing your newborn grow up to be an astronaut. The goal is to cut away that complexity where possible, and in the many cases where it's unavoidable, map and identify what remains so that practitioners can cope. With this in mind, Oxford researchers came up with a new kind of framework to navigate this sort of world, explaining non-adoption and abandonment of these technologies, and ensuring they can scale, spread to new systems, and become sustainable, in order that good ideas can work to make people better.
Okay, so sorry about the sound not being amazing. Can you hear me all now? Can you still hear me? Yeah, great. So NAS was the framework we produced. NAS stands for Non-Adoption, Abandonment, and Challenges to Scale Up, Spread, and Sustainability. The idea was not just to explain what we'd seen in our case studies, but to try and help people who were going to implement technologies in the future. Now, I thought I might pause here just to reflect on the use of the word complexity, because it's essential to NAS. And I've used it a couple of times without giving you a definition. And I wonder, has anyone on the call got what your thoughts are about the term complexity and what it means? Do you have a definition that you would turn to if I ask you to define complexity? Any thoughts from anybody? Pop something in the chat. No. What about giving me an example of a complex process? I'm going to try and explain complexity very briefly by comparing the idea of complexity with the idea of something being complicated and the idea of something being simple. So, a simple process, I have to go back to my slides, just bear with me a second. So a simple process might be making a sandwich. It's straightforward. Interactiveness, yes. I like someone's written in the chat about a definition of complexity, about being interactive. Completely agree. Making a sandwich, simple, straightforward, predictable, few components. You make a sandwich, you know what you're going to get at the end of it. A complicated process might be building a space rocket. There are many different components, many more than there are in a sandwich. Lots of different issues to be managed. However, building a space rocket is a project that can be broken down. Oops, my slides are moving on without me, which is a bit frightening. You can break down the processes of making a space rocket into different components. And if you took the ingredients and the processes from one place and did them in another, you'd probably get something that looked the same. So if I built a space rocket in Oxford and I brought the same engineers and the same ingredients and the same instructions to Oslo, I imagine I'd get a space rocket that looked similar at the end of it. This is an analogy, bear with me, I've never built a space rocket. But a complex process is the example of raising a child. And yes, these are my kids, and this is quite an old photograph now, and it's an entirely gratuitous opportunity to share the picture of them with you. But raising a child is a dynamic, unpredictable, uncertain process. It's hard to distinguish what we might call our inputs from the context. And importantly, the experience of raising one child doesn't mean the next child will be the same. So, having introduced you to my kids, I did say to them, is it okay if I show people pictures of you? And they looked at this and they said, those pictures are really, really old. And they are very old. I first made this slide a few years ago. The pictures are old then, and they insisted I showed you a more up-to-date picture of them. So here they are. And it's a nice illustration that you might be able to see the children they were in the picture of the children they are today, but you can't necessarily predict from the children they were what they would turn into. So I hope that illustrates the difference between simple, complicated, and complex processes. Let's return to health technologies. going the wrong way on my slides, forgive me. So we've done simple, complicated and complex, and now we've got the Nas Framework. So have a think about your technology that I asked you about at the beginning. What Nas does is give you, oops, I'm really sorry, my slides are moving on without my control. Nas gives you 7 domains. The idea is that within each of these domains, there are degrees of complexity, and there is complexity, so thank you, Bjorn, there is complexity between and an interaction between those different domains. Now, we can't necessarily control the complexity within those domains, or indeed between them. If we could, we wouldn't be talking about complexity. But what we can do is perhaps get to know those domains. We can learn about what's going on within them. We might be able to identify some aspects that are not complex and can be managed and controlled, and some that perhaps we have to go with the flow and understand that we cannot predict what the outcomes will be. So if you're implementing a technology, thinking about the technologies you thought about earlier, which of these domains are going to be more or less complex? Is it the condition, the nature of the illness, if you're thinking about a technology associated with health and illness that is inherently complex? Are there comorbidities? Are there sociocultural factors that affect experiences of that illness? Is it the technology itself that's complex? Is there an issue with the value proposition? Who is actually going to benefit from this technology being implemented? Are there going to be unexpected costs? What about the adopters? Are they happy using this technology? Will it require them to learn new skills? Will it require them to change their organisational routines? There might be organisational complexities, and there's very likely to be organisational complexities. There will be complexities in the wider system. Introducing new technologies is not straightforward when there are regulators and professional bodies and political contexts to consider. So we have produced a range of materials from NAS, including some materials which are designed to help people manage projects in health and social care, projects of implementation of technology. Again, very happy to share those with you. And we're interested in people using those as they introduce technologies into different environments. They can perhaps guide those implementation programs, as well as potentially evaluate them. I wanted to move on and just briefly outline some of my current research projects as well. I won't spend much longer talking. The first research project I just want to mention briefly is going in a little bit of a different direction, but I wanted to talk about it because it helps explain how we can apply some of these ideas about complexity. So I've been working over the last 18 months on a project called Osiris, which is optimizing shared decision-making for high-risk major surgery. The problem this study aims to address is that we have increasing numbers of older people having major surgery that have little awareness, both the patients and the clinicians, of the potential longer-term consequences of these surgeries to their health and quality of life. So the situation might be that somebody has a very good outcome from an operation, but actually the overall effects of perhaps the general anaesthetic, the experience of being in hospital, can lead to longer-term problems where they need ongoing care and support and potentially have a reduced quality of life. Osiris is a large programme of research that aims to address this by learning more about the outcomes of these people with epidemiological research, and also to co-design and introduce an intervention, a technology, into the decision-making process. The aim being that patients, families and clinicians will be able to weigh up more accurately the information about longer-term risks as they make their decisions about their care. Now, bringing a complexity-informed perspective to this has been helpful. We've been able to identify some implications for introducing a new technology into the shared decision-making process, because we have found in our study of how people currently make decisions about surgery that the process itself is complex. The outcomes are emergent. So introducing a new technology and new information into an uncertain and complex process is not going to necessarily produce the outcomes that we want. it may change that process, but it's hard to predict what will happen as a result. So we've got this is a study that we've done all the empirical work and we're just writing up. We will have some publications soon, we hope. And we've looked at how different types of consultation have emerged from the context, and the interplay between the interactions between clinicians and patients are affected by the context, different social, organisational and clinical contexts within which those consultations take place. So I'm just looking at the time. I've given you a bit of a rapid tour of the research that I've done recently. The current project I'm working on in Oxford, which is kind of running in parallel with virtual presence, is a project on video consulting during and beyond the pandemic. Now, interestingly, the rest of my team, or the rest of the research group, have actually been working on video consultations for nearly 10 years. Video consultations have been seen as important in the past in the NHS, but were not widely adopted. And clinicians that wanted to do video consultations faced huge problems around information governance, about getting linked in with the organisational infrastructure, about getting IT support and so on. And it's never been a real priority. Then, of course, we had the pandemic, and everybody, or so it seems, has shifted to doing video consultations. So we're now doing a rapid piece of work, building on the previous work of our research group, to understand how this rapid take-up of video consulting has happened. Of course, it's inspired and triggered by the pandemic, but what are the steps that have had to be taken by organisations, policymakers and clinicians to actually do the video consulting? We're doing a rapid evaluation across the UK of the adoption and use of video consulting, and some detailed case studies as well. So we've run a survey, and I'm doing some qualitative interviews with clinicians about their experiences of using video consulting, and we're also doing some virtual ethnography. Now, although this project was running in parallel with virtual presence, I've been struck during some of the interviews I've done recently about some potential parallels with virtual presence. And I wondered if there might be some connections to make. So this is really for us to think about and discuss together. I wondered whether you would like to see some interview data. I've got some extracts from interview data. Would that be of interest? Yeah. So I had a really interesting interview with a trauma therapist, a psychologist, who had started using video consultations during the pandemic. She started by saying how helpful she had found it initially to use video to continue relationships she had already made with her patients. So she said that was just easy to just carry on doing what we were doing. However, what she found surprising was that she was also able to build up relationships with new patients quite quickly. And she said it doesn't feel too much different from face to face. It might take a little bit longer, but you're able to sort of get that therapeutic relationship. She was confident enough with people she'd already met, but she also found it helpful to build up new relationships. And actually, in some ways, it was good because she says it slows me down as well, you know. So here we've got an example of the technology changing that interaction in a surprising way, and actually, in this case, quite helpful way. She talked about, so there was a break in her treatment with people because of the pandemic. So she didn't go straight to video consulting, there was a break. And then people she went back to after the break, they said it could have just stopped altogether, but the video work enabled them to finish their treatment episode. So I thought the way in which not just sustaining existing therapeutic relationships was enabled by the video consultation, but also the way in which new relationships could be developed was very interesting finding, which we're looking to analyse further. The other thing that I found really interesting was that this therapist explained to me some of the techniques she used as a trauma therapist. And she talked about the importance of, in trauma therapy, the importance of being connected. A lot of the underlying work, she says, is about connection and connecting with people. And she says, sort of regulating ourselves from one another. She talked about the importance of making eye contact and said, I will look specifically in the camera so they can see my eye contact. With the trauma therapy, she explained to me that she was trying to connect with people in the present to enable them to cope with traumatic memories. So having a connection was really important, and the video enabled that connection in a way that she couldn't get by phone. But interestingly, she also talked about somebody who she said was reluctant to use video. This was a patient reluctant to use video. And she said there was a strange intimacy on the video that we couldn't have face to face. Because of the restrictions around social distancing and wearing personal protective equipment, PPE, she would have to meet this patient wearing a mask, a visor, a gown, an apron, and stand 2 meters away from her patient. That didn't feel very intimate or connected. When they went on the video, there was a much better connection between them. So, as I say, a parallel study, but potentially one which might inform our work on virtual presence. Obviously, video consulting hasn't been set up in the NHS to address the problem of loneliness, but it's giving us some insight into how we can connect with people in difficult circumstances. There are some other connections as well from other interviews. I had an anaesthetist who works with an obstetric anaesthetist who works with women who are pregnant, and he talked about the importance of being able to connect with those women in their own environment and how that enabled a much more relaxed consultation, particularly when they had other children present as well. However, other clinicians, one doctor in particular, talked about how some of his patients didn't think it was appropriate to talk to their doctor on a phone or by video. It wasn't the kind of interaction they expected for a patient-doctor relationship. So again, we have an example of how the technology mediates and changes those relationships. So finally, just to conclude, if I revisit the research interests that I outlined at the beginning, I've tried to suggest some questions about how my research interests and the research of our research group might inform virtual presence. So I'm interested in that critical analysis of the relationships between health and social care policy, practice and lived experience. So some of the questions I'm hoping to look at for virtual presence are: how do policy discourses and problematizations of loneliness compare with discourses of independence and autonomy? And how do those discourses shape solutions? And how have these policies taken account of people's actual experiences of loneliness? With a broad interest in the interaction between patients and the public and services, I'm interested to know how loneliness technologies are introduced and perceived. So we've got some examples of technologies being used locally to Oxford, where Alexa has been introduced. The Amazon device was introduced in social care, specifically to address the problem of loneliness. We're also looking at how comp may be potentially introduced in that environment. And we're interested in the organisational response to the technologies as well as the individual user. Finally, specific interests in how these interactions are shaped by the complexity. So again, thinking about what does introducing these technologies do to those interactions? How do our relationships with each other change when we mediate those through technologies? So I think that's all I have. And I did say it'd be a bit, I was hoping it would be a little bit more interactive. I didn't really manage that. So thank you for those who have messaged me. I'm going to stop sharing my screen now. I do have references as well for those scholars amongst you, and I will share those in another way as well. So perhaps some questions